All right, good evening, or hello, wherever you happen to be, because I know we have some international attendees. I'd like to welcome you to the ANCAN webinar, and we will get into the details of the program in just a couple of minutes. A couple of administrative things I'd like to just go over from a housekeeping point of view. I'd like everyone to, except for the participants, to remain on mute. And also, if you would turn off your webcams, otherwise that can create some distraction. For questions, you may enter a question at any time throughout the presentation. The questions will be accumulated in the Q&A box. You'll see that in the panel over under the questions panel, and you will enter them, and the moderators will then group them all together and present them to Dr. Klotz after his presentation. Please keep in mind, and I'll hit that again in a moment, but make sure that your questions are more generalized. We're not going to try to attempt to do any diagnostics. Okay. Here comes the information that I wanted to present to you, that the session is not intended to be anything other than an educational presentation. Nothing that is presented tonight is to be considered any sort of medical advice, and it should be referred to your doctor for any additional guidance that you might need. I'd also like to thank our sponsors. We have Myovent, Pfizer, Advanced Acceleration, Foundation Medicine, as well as our other co-partners, Zero, PCAI, ASPE, and the Prostate Cancer Support of Canada, and of course the Walnut Group from Canada. And with that, I would like then to turn this over to Rick Davis, the founder of ANCAN, for the official welcome.
Yeah, hello everybody. It's great to have such an international audience, and we're thrilled that we think this is the largest attendance that we've had this year. We're back to last year's numbers, and we know that Dr. Klotz is a very popular international item. I think we're second in line to receive him. I think he's back up again next month, but we're very happy that I think we've got the best numbers that he'll see anywhere. For those of you who don't know, ANCAN is a virtual support group. We were running virtual support groups back in 2010, started using a platform like this in 2015. And when COVID came along, we kind of knew what to do. So we run a whole number of support groups for a lot of different conditions, but our mother lode is prostate cancer. We have 11 groups a month for prostate cancer, and we invite you to sign up. If you're not already signed up, join our groups. They're free and drop-in. We have an active surveillance group, low intermediate group. We have a high risk recurrent and advanced group, and we have a group for men with stage 3 and 4 under 60. And I suspect we've got representation from all 4 of those groups today. So with that, welcome from ANCAN, welcome to Dr. Klotz, and I will pass it over to Howard Walensky, who will formally introduce Dr. Klotz.
Well, good evening, everybody. I hope you can hear me because I had problems getting in. But we are fortunate tonight to have as our speaker Dr. Laurence Klotz. I call him the prostate whisperer. With the advent of PSA testing as a screening tool back in the 90s, many men were being diagnosed with prostate cancer, too many. Some were being overdiagnosed and overtreated. With colleagues at Sunnybrook Health Sciences Center in Toronto, Dr. Klotz and his colleagues co-developed active surveillance as a strategy to help men with low-risk Gleason 6 prostate cancers defer or avoid altogether radical surgery or radiation treatment. If it wasn't for Dr. Klotz and other pioneers like him, we probably wouldn't all be gathered together virtually tonight. Dr. Klotz even coined the term active surveillance to describe this revolutionary approach to managing low-risk prostate cancer. But Dr. Klotz is more than an icon for active surveillance. He's also been a pioneer with focal therapy to avoid full-gland treatments. And now he's leading the charge with liquid biopsies designed to help men avoid or delay regular biopsies. Now, funny enough, Dr. Klotz had a different career in mind when he was getting ready to go out into the world. He wanted to be a jazz musician, but his jazz teacher persuaded him by taking him to his own performance in a Chinese restaurant in Toronto that the life of a jazz man wouldn't be copacetic, as the jazzmen say, I think. Instead, to our benefit, Dr. Klotz went into the family business, urology, following his dad. He's a Canadian and a hockey player. I think he wants to win the Stanley Cup. Good luck on that. He got his MD at the University of Toronto and trained in uro-oncology and tumor biology at Memorial Sloan Kettering Cancer Center in New York. Dr. Klotz, I should point out, continues to play music as a pianist in an all-urologist band called The Void. Think about it. I'm going to turn the platform over to Dr. Klotz.
Okay, thanks, Howard. Let's hope everything works here. I hope you can see my screen. I'm assuming you can. So that was a lovely introduction and very, very flattering. And Howard really has been a tireless supporter and promoter in this area. And he gave me fairly specific instructions for tonight to talk about active surveillance, including the history of how this developed. And I would say it's quite an interesting and perhaps illuminating story in terms of what it takes to change practice. And also to talk about partial gland ablation and of course, kind of the state of the art of active surveillance. So I'm going to try and cover quite a bit, and we should have time for questions and discussions at the end. And hopefully my slides will advance. Let's see what happens here. I have just two disclosures that are relevant to this. I got research support from Exact Imaging. I'll talk about their product. And I'm a consultant to MIR Scientific. I'll talk about that biomarker platform as well. So we've made a lot of progress in this field in prostate cancer in general, in management of localized disease specifically. This is a summary of what's happened over roughly the last 10 years. Much more known about the molecular genetics of grade group 1 compared to higher grade cancer. Very reassuring in a lot of ways. I'll come back to most of these topics, at least to some degree. Patient selection, the impact of age and race, germline testing for BRCA and other mutations, imaging, the game changer has been MRI, but we now know more about its limitations, novel modalities like micro ultrasound, which I'll talk about, PSMA, radiogenomics, which means correlating very detailed analysis of the pixels, the pixel pattern MRI with gene expression, an emerging field. The biomarker story, the limitations of existing ones, the promise of new ones, predictive nomograms, modeling to show how robust this approach is. We have long-term outcome. This is important because for a long time, the opposition said, you know, you wait, you follow patients long enough, and you're going to start to see a lot of prostate cancer deaths. And this simply has not happened. We now have worldwide probably well over 1,000 patients who've been followed between 15 and 20 years, and you can draw a lot of conclusions. And a rise in mortality has not occurred. How to follow patients properly, influences in the tumor microenvironment, and I'll come back to that. Some very fascinating information, for example, on the impact of obesity. The effect of dietary modification, other innocuous interventions to improve general health and also reduce the risk of prostate cancer mortality and progression, And we have a lot of systematic reviews and meta-analyses addressing a lot of these controversies. So just, I usually speak to my colleagues, and I really enjoy speaking to groups like this one, but it's not my kind of normal coloration. So just, there's a lot of acronyms in the talk. I'll just, PCA is prostate cancer, GG stands for grade group. Grade group 1 is what used to be called Gleason 6, grade group 2, Gleason 7, and so on. OS is overall survival. These are like the oncology lingo. CSS, cancer-specific survival, likelihood of dying of cancer versus other causes. PFS, progression-free survival. AS, active surveillance. Ultrasound. And this, this is called a forest plot, and this is how we show massive amounts of data in a very simple way. So this is a series. In this example, this is 7 individual trials, and the effect of these trials comparing, say, in this case, corticosteroid to placebo. You have the benefit of corticosteroid, say, on the left, of placebo on the right. The bigger this square, the more patients in the study. The shorter these lines, the smaller the confidence limits. In other words, the less variation. So I'm going to show a few of these, and I just hope you can appreciate that it's not that hard to interpret. And then all of these have at the bottom the overall effect, which is if you put all these studies together, what do they say? So here you can see there's a significant benefit to corticosteroids. So it's just a quick example, and you'll see some examples of this in my talk. So first of all, the start. So it was no secret back 20 plus years ago that overtreatment was a problem. And we knew really from autopsy studies done in between the 60s and the 70s that if you did autopsies on men and looked at their prostate, these are men dying of completely unrelated causes, you would find small foci, usually low-grade prostate cancer in a large proportion of them. And a landmark study, which influenced me a lot, came out in the early 80s when I was a resident by Walid Sacker in Detroit, which was really an autopsy study in men who were victims of the Detroit Knife and Gun Club, which was quite active in those days. So these are men of all ages, mostly dying of violence. And the likelihood of harboring low-grade prostate cancer was the age as a percentage, like 30% of men in their 30s had prostate cancer. And this came as such a revelation. So what were we doing treating these patients radically when we found it? It didn't make sense. And yet in that era, even in the 90s, when we got started with this, 95% of men with newly diagnosed low-grade prostate cancer were getting radical treatment. So I wasn't comfortable with this, and I went out for a lunch meeting with my 2 pals who were radiation oncologists, Richard Chu and Cyril Danjou. Richard ended up at the Mayo Clinic. Cyril Danjou retired a while ago. And we had a self-assignment to come up with some strategy to reduce overtreatment in our practice. And the context, I had trained with Willett Whitmore, who was really the head of urologic oncology at Memorial Sloan Kettering, where I did a lot of my training. He was really considered the father of this field, very enlightened guy. And his aphorism was, is cure possible when it's necessary and necessary when it's possible. In other words, the cases you cure are the good ones with indolent disease. The ones who really have aggressive disease may not be curable in a lot of cases. In other words, biology is king. So that was kind of I'd kind of imbued that when I was at Sloan Kettering, like mother's milk. And then these were guys, Nicholas George from Manchester, Jerry Chodak, who died from Chicago, who unfortunately died a couple of years ago, a very untimely death, and Peter Albertson from University of Connecticut had all published these papers showing that patients, particularly with low-grade disease, had a very low rate of mortality from prostate cancer, even if they were treated conservatively. But no one really had proposed anything except either treat radically or don't do anything. So we reasoned, wasn't rocket science, that our patients we were seeing had a fairly low PSA, just mildly elevated, and low-grade prostate cancer. And the patients who had advanced disease had a high PSA. So and higher grade cancer. Let's follow them instead of treating them. Track the PSA, treat them if the PSA goes up quickly, repeat the biopsy from time to time, and treat. And I applied to the new Prostate Cancer Research Foundation in Canada. This was their very first grant. They only gave out one. It was $35,000. We were successful in getting it, and we set up a prospective database, and that's what led to the whole thing. And then 5 years later, so this is around 2002, we had our first publication, 250 patients, no deaths. And that's when the firestorm started. And you had Pat Walsh, who was the world's most famous urologist at Hopkins, who had described the nerve-sparing radical prostatectomy that led to this massive increase in surgical resection. And he said very convincingly that the best patients for a nerve-sparing prostatectomy were Gleason 6 because they tended to have negative surgical margins. You had this data that these patients were all being treated radically, and the pundits really believed that this conservative approach was wrong, and this was called unethical. I was on a panel more than once where people on the other side said patients will die unnecessary deaths, and you, Dr. Klotz, will be responsible for this. So it got pretty heated, and my American friend said to me, "You'll never convince American physicians to stop treating patients radically, the surgeons and the radiation oncologists." But I kind of had the conviction of the zealots, and I really believed that we were onto something. And over time, the world changed. So first of all, other groups started doing this, and now there's about at least 10 or 12 large prospective series in the literature. Prospective meaning that the patients are entered into a kind of formal protocol and followed. And beginning around 10 years ago, basically opinion changed drastically. This was partly motivated by the US Preventive Service Task Force that said we should stop screening for prostate cancer with PSA because there's too much overdiagnosis and overtreatment. And they, of course, changed that recommendation a few years later, largely because of the adoption of active surveillance. And now active surveillance is considered the standard of care by guideline groups all over the world. Now, I just heard today that NCCN has just modified theirs. We'll come back to it. Now it's one of 3 options. I don't think that is a major change, but we can maybe talk about that at the end. So now just to get into the meat of the topic. So first of all, what have we learned from the molecular genetics of prostate cancer? You know, you have these 2 patterns, pattern 3 and pattern 4, that constitute the 2 patterns in about 95% of newly diagnosed patients. And grade group 1 is Gleason 6 or all Gleason pattern 3. Grade group 2 and 3 are combinations of 3 and 4. Grade group 4 is all Gleason 4, 4 plus 4 or 8, now called grade group 4, and so on. So these 3 and 4 are like night and day, and that is a key point. Pattern 3 resembles normal cells genetically in 90+% of cases. A few percent of them have abnormal genetics, and I'll come back to that. Whereas Gleason 4 has the real molecular genetic features of cancer and behaves like cancer. The implications of this normal genetic pattern is that Gleason 3 is a non-metastasizing cancer, and this is absolutely a fundamental observation that's supported both by what we know about the molecular genetics and clinical observations in many tens of thousands of patients. There are almost no patients anywhere in the world who have only pattern 3 who have metastasized. So this raises the question, is it really cancer? And there's a controversy at the moment. There's a group led by Scott Egener in Chicago that's trying to convince the community, and particularly the pathologists, to no longer call Gleason 3 cancer. The problem is it has a lot of the features of cancer because it does invade occasionally. It invades locally, which is a different process from spreading distantly. That's what kills patients. And there's other cancers like basal cell cancers of the skin and some brain tumors that are clearly cancers, but never ever metastasize as well. So I don't think this is going to change so fast. If it did, it would make our job a lot easier. And it's kind of an ongoing issue. So this is one of the few slides I'm going to show that actually has some molecular genetics on it. This is called a heat map. So this is kind of organized according to how abnormal the mutations are in individual cancers. So this is a huge number of patients. Each one of these little vertical lines, an individual patient. The light blue in the second line is the grade group 1, the low-grade cancer, Gleason pattern 3. The dark blue is higher grade cancer. And this is calculating what's called the average genomic risk, or what is the mutational burden? How bad are the molecular genetics in these cancers? Because of course, cancer is a genetic disease, and it's a genetic disease that affects the genes involved in cell proliferation, cell growth, the regulation of the behavior of the cell. The more genetic aberrations you have, the more aggressive the cell tends to behave. So in this, what you see is it's not completely black and white. 2% of the grade group 1 are in the highest 25%, the highest quartile of the genetic aberrancy. As soon as you have any elements of grade group of Gleason pattern 4, which makes it grade group 2, it's 7 times higher. So that just emphasizes what a huge difference there is between grade group 1 and 2. And the vast majority of these grade group 1s have normal genetics. So now on to the clinical side, and just a brief summary of this. It's kind of a sky-high view. These are the 7 or 8 large, mature, meaning they've got long-term follow-up. And I want to compare the top 2, which is ours in Toronto and the group at Hopkins. And the reason is these are at the 2 opposite ends of the spectrum. We were very inclusive. We wanted to really see how well this worked once we got our feet wet, how well this worked in any patient for whom it seemed reasonable approach. So we include patients, some of them were grade group 2, some of them had a PSA above 10. We weren't too worried about being sued. It was kind of the benevolent Canadian environment from a litigation perspective. The Hopkins group, for multiple reasons, was very restrictive. So only patients with Gleason 3+3, they could only have a small amount of cancer, only 1 or 2 cores positive, no more than 50% involvement, a low PSA density. And now we have follow-up. They have very large cohort like ours, both have around 1,500 patients. We have 1.5% mortality at 15 years. And when we published this, I was very proud of it for a while. You know, these are prostate cancer patients, a lot of them treated conservatively, all treated conservatively initially, some eventually treated, but 1.5% seemed pretty good. And then they came out with theirs, 0.1%. So they did considerably better. Both of these are low numbers. But if you're one of those patients, obviously, you know, it's very, very important. And it turns out that it's all about patient selection. Just another recent study from Sloan Kettering where they also got a very low rate of metastasis, comparable to ours, 1.5%. They did have about 300 patients who were grade group 2. But I just want to show that these 2 curves are the likelihood of upgrading and the likelihood of treatment. And this is what it should be. In other words, the only reason to treat patients who are grade group 1 on surveillance is if they're upgraded. They weren't treated for a rise in PSA. They weren't treated with very few exceptions, they weren't treated for anxiety. They were treated for grade progression only. The outliers. What about very young men or those who have other risk factors like African Americans, Canadians, strong family history. So we now know a lot more about this. The concern for the first, I don't know, 15 years or so was you find cancer in a young man, maybe it's more aggressive, even if it's low grade. And we now know it's actually the opposite. So we combined our cohort of younger men, this is under age 60, with the group at Harvard. We had more than 400 on surveillance with up to 15-year follow-up. Absolutely no difference in the rate of progression or anything else. We had one patient out of 417 who developed metastatic disease. Of course, that one is one too many, but you know, you're never going to get 100% in this field. So the other key point about this is that higher grade prostate cancer, which is more life-threatening, develops with age. So the younger men are much less likely to have higher grade cancer that you've missed. And that's another reason why active surveillance works so well in young patients. So young age is not in any way a contraindication, with one caveat, and that is the whole story isn't 30 years old yet. It's 20 plus years old. We don't have 30-year follow-up, but there's no reason to think that things are going to change dramatically going forward. And then race, the issue about race, which I would say is now confirmed by a number of groups, is that the difference between Caucasians and blacks is that black men have a higher rate of harboring higher grade cancer. So the biopsy shows grade group 1. We know in the overall population, about 30% will have higher grade cancer that you don't know about. I call it misattribution of grade. In African Americans, it's more like 40 to 45%. So you have to look harder for it. MRI, repeat biopsy, but grade for grade, it's the same. So in other words, if you only have grade group 1, they have no greater chance of progressing to metastatic disease or running into trouble. So race is also not really a major issue for surveillance, just recognizing that you have to scrutinize, just like you scrutinize, you have to scrutinize the men carefully to make sure you're not missing anything. We do that now quite well with the more advanced imaging. And these curves just show the rate of progression. You can see it's higher in the African Americans, but not dramatically higher. It's about a 10% difference. The next area that's really advanced a lot in the last couple of years is this story of DNA repair defect mutations in the germline. So that's a bit of a mouthful. What it means is that we now identify families where there is an inherited defect. That means every single cell in your body has the same mutation in a pathway that is responsible for correcting errors in gene replication. So, you know, our cells are dividing all the time. Every time they divide, they've got to copy with precision the 27,000 or so genes in each cell, 1 billion base pairs, and mistakes get made. And we have a lot of mechanisms that exist in each cell to correct these errors. And the cell either corrects the mistake or it undergoes cell death. Either one is acceptable. What's not acceptable is to accumulate a lot of errors over time, because then you get a change in the cell's behavior and potentially malignancy. So in the normal, the bottom is the sporadic tumors in the normal person who doesn't have a defect in these in this pathway. And the way it works is over a long period of time, say 15 to 20 years, you have a gradual alterations in some genes. There's both tumor suppressor genes, which are lost, oncogenes, which are gained or mutated. And it takes a long time, and over time, gradual accumulation of molecular abnormalities, and then more aggressive cancer, and it can spread and die if it's not managed. With the families that have these mutations. And the most important gene is called BRCA2. It was originally described in breast cancer. That's why it's BRCA2. There's a whole slew of them: BRCA1, ATM, CHEK2, etc. With these, as soon as you get the initial event, boom, you have a whole pile of other genetic alterations that occur very rapidly, not over 15 to 20 years, but over a relatively short period of a few years. So if you're, contemplating active surveillance over a long period of time, and you know the patient has this inherited defect in the ability to repair genetic errors, it's not a good strategy. And we now have a very small amount of clinical data to support this. This is a group from Hopkins, 26 patients with one of these DNA repair germline mutations. And this is the likelihood that this is managed with surveillance. These are grade group 1 patients. So the bottom left, you see the BRCA2, which is the most serious one, about almost a 3 times greater likelihood. HR stands for hazard ratio. That means how much greater the risk is of developing higher grade cancer. At 10 years, it was about 80%. Probably the real figure is 100%. They just missed some of them. So these patients basically should have, these are the one group of grade group 1 cancers that should be treated with surgical removal, even though it's low grade cancer, because it's just not a good strategy to count on the cancers remaining indolent. The next area is imaging. So imaging that has transformed our field, this MRI imaging. So this is a case of a guy, this is a prostate MRI. First thing is, you can see the amazing detail. It really is extraordinary. You see all this growth and irregularity in the prostate with incredible precision. This is a patient who originally had a systematic biopsy, 1 positive core, 10% Gleason 3+3. Now, in the olden days, he would have had a confirmatory biopsy at a year, probably would have shown the same thing. Today, he gets an MRI, and there is the lesion. Now, imagine, I don't know if you can appreciate it, but to hit that with a systematic biopsy done transrectally, basically impossible, very unlikely. This is an area that's very hard to target with systematic transrectal biopsy. So that was now targeted, showed Gleason 4+3, and this is called a whole mount of his, meaning the whole prostate is put on a slide, a section of it. And there is the totally insignificant grade group 1, which is just a little micro focus of nothing. And he had a large cancer here, actually about 2 or 3 times the size of what was seen in the MRI, which is quite common. And that's the life-threatening cancer. So there's a case that might have been that 1.5% of mortality, because in the olden days, we would not have found this very likely, and it may have very well progressed and spread and been lethal. Today with MRI, we find it early, diagnose it, and treat it. So this has really dramatically improved the whole approach. Now, we're in the MRI era, and increasingly we've learned about the limitations of MRI. So I think we all hoped that MRI would find all these cancers. It's good for large cancers. It's not good for small cancers. So this is a study done from UCLA, 588 men undergoing surgery who had an MRI, and how did the MRI correlate with the pathologic findings? And the first problem is that the majority of men, especially with more high-grade cancer, have multiple foci or multiple areas of cancer. And in these men, this is the bottom right here, where there were multifocal cancers. If those cancers were less than 1 centimeter, which is still a pretty decent size, 80% of them were missed on MRI. And overall, MRI missed 40% of the clinically significant cancers. So we now know it's a huge advance, but it's not perfect. And specifically in the surveillance setting, you have these three scenarios. So the first two are the good ones, where everything is stable. The MRI is stable, the repeat biopsy is stable. These are taken 3 or 4 years apart. Then you have progression of the MRI. So you can see here it goes from small to large. The dark area is cancer, and confirmed on biopsy. But you also have this, where the biopsy shows grade progression, but the MRI hasn't changed at all. And unfortunately, our hope that MRI would show the progression hasn't been borne out. And this is a recent publication from Memorial Sloan Kettering, 270 men on surveillance, MRI and biopsy 3 years apart. In about a third of the men whose MRI was completely stable, there was grade progression to higher grade cancer on the biopsy. So again, not perfect. So this leads me to the next topic, which is this high resolution micro ultrasound. So ultrasound's been around for a long time. It really came in around the same time as the PSA era and allowed us to visualize the prostate and do systematic biopsies through the prostate. But it was never any good for imaging cancer. The resolution was not great enough. And conventional ultrasound has a resolution of around 6 to 9 megahertz. This high resolution micro ultrasound has a much higher frequency, and the result is higher resolution, about 3 times higher, 70 microns versus 200 microns. A micron, there's 1,000 microns in a millimeter. So this is 71,000, 700ths of a millimeter. And this is the diameter of a prostatic duct. And what it means is that you can see alterations in the ductal anatomy. The prostate is a gland, it secretes fluid, and these fluids pass down a duct. And alterations in the ductal anatomy is a major feature of cancer, particularly higher grade cancer. And the same principle with MRI is also based, the alterations on MRI are also based in changes in ductal anatomy. So this now allows you for the first time to use this quite simple technique compared to MRI of imaging cancers. And it looks like a regular ultrasound. The cost is roughly the same as a regular ultrasound. And it's quite easy to learn how to recognize these patterns. So I'm very excited about this. And this gives you an example. So here's the prostate. And here's the cancer. Now, you probably would have seen this on MRI as well. They are concordant, or they both show cancers in about 75% of cases. But if you saw this on MRI, the radiologist would have to recognize it. And then he does what's called co-registration and fusion. So this image is fused from the MRI overlaid onto the ultrasound. And assuming that's been done correctly, the guy doing the biopsy then targets this lesion, which is invisible on regular ultrasound, by using the fusion targeting of the MRI. Many pitfalls with that complex process at every step of the way. Whereas here, you do the high resolution ultrasound, you see the lesion, you line it up with the needle, and boom, there's the biopsy. You can be basically 100% sure that you have targeted that thing correctly. And this is where there's a shift now to transperineal biopsy, which I think is laudable. This is a transperineal approach. Transrectal is coming up from the bottom. Transperineal is coming in from the side, so it's the same idea. And so it's one-stop shopping. You don't need the two. This is another one. This is an anterior lesion. So this could have been that case that I showed the first MRI. This is the kind of thing he had, this dark lesion up here. And again, you probably wouldn't see this with conventional ultrasound. With high resolution, you see it and target it, and there goes the needle. So this technology is now about 4 or 5 years old. This was actually developed at my institution, And so I got one of these quite early on and have really, I'm really quite impressed with it. And this is an early publication from actually the first 9 or 10 centers that started using this. And this was data was just published by me about a year ago that shows the sensitivity and the specificity compared to MRI. And this data is not perfect. It reflects the learning curve, but you can see the sensitivity, meaning the likelihood of finding cancer if it's there, was actually better with ultrasound than with MRI. This is one of those forest plots I warned you about at the start. And the specificity here was about the same between MRI and ultrasound. So this has been very reassuring. And now there's about at least 6 or 7 groups around the world that have published about this, and they all show the same thing, that it's very comparable to MRI. But MRI is a very expensive technology. There's issues about access to MRI all over the world. The caveats, the data is preliminary, maybe 2,000 patients reported on so far. Not everything's been published. Some of it's just abstract form. We have level 1 evidence for the value of MRI from a number of prospective randomized trials. There's still some validation required, but I think it's really got a future. And the places that are really excited about this are the developing world, where providing MRI for every patient with an elevated PSA is really a pipe dream. And so there's just tremendous interest in this. Also in the United States, and it's really taking off. The next topic is the issue of compliance. So we wondered, does it really matter how we follow these patients? Maybe the grade group 1 disease, it's so indolent, it's so non-threatening. Do we really have to keep biopsying patients and following them? And it turns out it really does make a difference. So we went back and looked. This was just published last year. The patients who complied, particularly with the 1-year confirmatory biopsy, which was our standard protocol, versus the ones who didn't, did much worse, and they had more progression. They had more, this is cancer specific survival, metastasis-free survival, and even overall survival. So follow-up is important. As a clinician, you must follow these patients quite closely, not frequently, once a year, PSA every 6 months, but they need to be re-imaged and re-biopsied periodically. The next area is intermediate risk disease, the Gleason 3+4s. We didn't have such a good experience. We found, in sharp contrast to the grade group 1s, that as soon as there was Gleason 4 present, we had 30% metastasis rate at 15 years. Now, this was pre-MRI, so it's better now, but we've become much more restrictive about including patients with grade group 2 on surveillance. There is a role for it, but you have to be selective. Biomarkers. Lots of different biomarkers. You can look at blood, you can look at urine. There's a lot of interest in looking at semen. It's an obvious source for biomarkers for prostate cancer, because that's where it comes from. And you can look at protein, DNA, RNA. And this is a summary of the 8 or 9 commercially available biomarkers on the market that are all trying to identify the presence of clinically significant cancer. They're in blood, they're in urine, they're in tissue. The price varies from about $500 for the ones in blood and urine to about $4,000 for the tissue-based ones, because it's quite labor intensive. This is AUC's area under the curve, which is a combination of the sensitivity and specificity. It's really the performance of the biomarker. The one with the highest performance is the Select MDX. It's a urine-based marker, but I emphasize none of these have been compared head-to-head. They've all been compared in their own populations, and probably they all work comparatively well. And there's a lot coming down the pipe too. This whole area is on fire, and we are going to have an effective, accurate biomarker even more than we have today in the very near future. And the one I just want to emphasize, because I'm quite involved with it, is this exosome, urinary exosome microRNA platform called the Sentinel assay. So exosomes are these submicroscopic structures that are shed by cells. A typical cell may shed thousands of these per day, and they are packaged with very specific material. And the material includes what's called microRNA. So hopefully most people know the basic pathway of life is that DNA codes for RNA, which codes for protein. But the RNAs that code for protein are called messenger RNAs. These are different. These are microRNAs. They're very small segments. They're regulatory. They influence how genes are transcribed, whether the messenger RNA is translated into protein. They have a regulatory function, and they are specific to cancer in many cases. This just shows what they look like, very simple little organelles. And there's tens of thousands of these have been described. So the Sentinel assay studied a huge number of them and pulled out the 442 that each one of which had some predictive value for the presence or absence of cancer. And this has now been turned into an assay that tells you whether cancer is present at all, whether it's grade 1 versus higher grade cancer, or grade 1 to 2 versus grade group 3 or higher cancer. And this really seems to work. So this is the initial publication, which came out last year. This is the presence or absence of cancer, the area under the curve, 0.97, a lot better than the other assays. And this is for the presence of grade group 2 or higher cancer, 0.96. So this is still being validated. I just presented the updated data at the AUA. It looks very much like this. I mean, it really looks promising. So this hasn't been approved by the FDA, but it's coming, and I think it could be a game changer. The next topic I want to touch on is the tumor microenvironment, and particularly this obesity story. So there's a lot of evidence that obesity is not good for prostate cancer. I mean, aside from the cardiovascular issue and so on, but obese men have higher rate of prostate cancer metastasis, higher mortality, and we've only just recently learned why that is. So this is a New England Journal publication that just came out, and it turns out what happens is that obesity induces a metabolic tug of war between the tumor cells and the immune cells, which are called T cells, amongst others. And what happens is, paradoxically, in obese men, the tumor cells eat up all these fatty acids, and the immune cells are deprived, and they become dysfunctional. They have impaired activity. And the result is that the balance between the immune system and the cancer is altered, and the cancer is free to progress. And so this really explains, for the first time, why obesity is not good for prostate cancer. So this leads me to the last part of the talk about surveillance, and I was going to talk about focal therapy too. I'll try and make that quick. Can we prevent failure with innocuous interventions? So a lot of guys don't like the idea of surveillance. They feel it's too passive. They want to do something. There's other health benefits to some of these interventions, and maybe they're good for the prostate cancer. So there's two groups of these. These are what I call the motherhood recommendations. Heart healthy is prostate healthy to a large degree. So number one, stop smoking. Not good for prostate cancer, not good for your health. For clinicians, this is the single most cost-effective intervention in all of medicine. Telling a newly diagnosed cancer patient he's got to stop smoking really works. Exercise. This is a summary of the 8 or 9 different ways that exercise improves the tumor microenvironment. If it were a pill, we would all take it. Exercise is really good for general health, but also specifically for prostate cancer. And then finally, dietary modification, avoid obesity, moderate red meat intake, increase fruits and vegetables. So, you know, everybody knows this stuff. They don't always do it, but it's motherhood. Just one recent publication just came out last month that randomized patients on active surveillance between high intensity interval training, HIIT. So there's like 3 months of getting these guys to really work their butts off. And they had a prostate cancer endpoint, which was PSA kinetics, and it actually showed a benefit that the PSA went down significantly in these men who had the very intensive exercise. So this is not definitive. It's a small study, 52 men, but it's still a nice signal that this really means something. Then the other question is diet. Should men dramatically alter their diet because they've been diagnosed with low-risk prostate cancer? And this is a recent study that was 478 men on surveillance, randomized between aggressive behavioral intervention to switch to a more vegetable-based diet, more than 7 servings a day of vegetables, versus a pamphlet. And it had a prostate cancer endpoint. Did this make a difference in terms of the likelihood of progression or higher grade cancer? Totally negative study out to 2 years. Absolutely no difference in PSA level, rate of rise, upgrading on biopsy. So, you know, I think every doctor and most people understand that your diet over a lifetime really influences your health. But once you're diagnosed with prostate cancer, at least in the intermediate term of several years, it probably doesn't make much difference. So I just encourage patients, eat a heart healthy diet, you know, don't overeat too much, and enjoy life. And then there's what I call the proactive interventions. I just emphasize none of these are supported by randomized trials, although the studies are going on now. But these are all supported by inferential data that's quite compelling. Vitamin D, low-dose statin, and metformin. So this is for the guys who say, doctor, I want to do something. Isn't there something I can do? For people who live in a northern climate like Canada, vitamin D deficiency is ubiquitous in the older population. And this is a meta-analysis, another forest plot, showing the relationship between levels of vitamin D and prostate cancer mortality. And there's a significant increased mortality in the patients who had low levels of vitamin D. And this costs about 3 cents a day. It's completely harmless at that dose of 1,000 to 1,500 units. The next is statins. So this is a long story, which I really don't have time to go into in detail, but there's a lot of evidence that the statins like Lipitor and Crestor, the cholesterol drugs, are actually prostate cancer drugs as well. And they influence a pathway called the mevalonate pathway that leads to many important molecules that are stimulatory to prostate cancer. So this is aside from the benefits in terms of lipid profile, lower rate of metastasis, of death, overall mortality, and prostate cancer mortality in men on statins compared to men not on statins. And given the other health benefits of statins, I really encourage patients to go on this, even if their lipids are okay. I warn them their family doctor is going to say, what is that guy Klotz thinking putting you on a statin? Your lipids, you don't have hypercholesterolemia. Cholesterol is okay, but it's really for the prostate cancer benefit. And then finally, the metformin story. Metformin looks increasingly like a health promotion drug. This is an old diabetes drug. At a low dose, it does not cause low blood sugar at all. And it has several mechanisms by which it looks like it favorably influences the progression of prostate cancer. And this is, again, these forest plots, a compendium of 30 studies involving 1.6 million men, and improved overall survival, improved cancer-specific survival, improved recurrence-free survival, very significant amounts. Again, non-randomized, these are population-based epidemiologic studies, but boy, to me, it's quite convincing. And it is also a very harmless drug at a dose of 500 to 1,000 milligrams a day. And so finally, just to show the progress. So this is the adoption of active surveillance around United States, West, Northeast, South, Midwest. The blue line is the active surveillance curve. You can see overall it's around 60% around the country. In Canada, it's more like 90 to 95%. Somehow we adopted this much more readily than in the US, but it's all, you know, in the favorable direction. And I think it's amazing to see how opinion has changed over the last 10 years or so. All right, I'm going to just move on to the focal therapy story because I was asked to address that. So I'll cover this quite quickly and then we'll open the floor. Call it focal therapy uses and misuses. So the appeal of focal therapy is that I've been focusing on grade group 1, and this is really about the grade group 2 patient who's got Gleason 3 plus an element of pattern 4, but particularly if it's less than 50%. These are often indolent cancers. And they're also cancers that even if they do pose a threat to the patient, often takes many years. So there's little they lose by trying a more conservative approach. And then you have the opportunity to salvage the patient with a second treatment if it doesn't work. And it's unlikely that they will become incurable during that period. It's a change of the paradigm, the male lumpectomy. There's lots of tissue to preserve. So the average cancer is, say, 2 cc's in a 40 cc prostate. It's only 5% of the volume. You can preserve, you know, 60 or 70% of the prostate, and that results in preservation of function. So if you preserve prostate tissue, you are definitely less likely to get erectile dysfunction and incontinence. Increasingly, we're recognizing patients who have a solitary lesion because they have an MRI before the biopsy, so it's a targeted biopsy. And we also have a lot of molecular genetic techniques to try and identify the patient who is not a candidate. And there's many methods. Now, the misuse is that a lot of tumors are multifocal. I showed earlier that the MRI can miss these small multifocal lesions. We don't really know how to monitor these patients. I'll come back to this issue of disease of injury response as may have an adverse effect. There's some data that the salvage treatment, particularly if it's surgery, has increased risks. We don't have randomized trials, and the multiple methods that are available for this is also a limitation because we don't know which is best. And just by way of example, this is a patient who had breast cancer 25 years ago when the standard was a radical mastectomy, and that's basically what we're doing mostly today when we treat prostate cancer. We're treating the whole organ, and this is today a lumpectomy with adjuvant radiation, breast preservation, and why aren't we doing this more for prostate cancer? So many methods. You can use heat, which is in most cases either ultrasound energy or laser energy, light, that's converted to heat in the tissue. There's HIFU, TULSA, Insight Tech. You can freeze it. You can radiate it with focal brachytherapy. You can shock it with electroporation, the nano knife some of you may have heard of. You can actually remove part of the prostate. This makes no sense to me, but people are doing it. And you can treat a small area, partial area, hemi, hockey stick, and so on. So a lot of variables to weigh. And this is just a summary of some of the results. HIFU, focal laser ablation, cryo, IRE is electroporation or electroshock. And you can see that there's definitely preservation of continence, 95 to 100%, preservation of erectile function, 75 to 100%, very low rate of complications. So this, I would say, is not controversial. The focal approach gives better quality of life than radical treatment. And there is many controversies in the area, but that's not one of them. The oncologic outcomes, or the how well do they cure cancer? roughly about 60% overall have negative biopsies after focal therapy. This is 91% with the Insight Tech, but again, these are not head-to-head comparisons. They all reduce prostate volume. The Tulsa, which is the one I'm involved with, really dramatically reduces the volume by 90%. Pardon me. Sorry, I don't know what happened there. I just jumped ahead about 8 slides. Here we go. One of the concerns I have is the concept of focal therapy as snake oil medicine. So snake oil medicine is ineffective treatment for a self-limited or clinically insignificant disease. So if we start doing focal therapy for grade group 1 disease that doesn't need any treatment, the patient may think he's being cured. The doctor gets his fee and everyone's happy, but this would not be a good situation. So I think we have to be wary about this. The other thing that concerns me, this is more theoretical, but with radiation, we know if you treat, if you have inadequate treatment, so let's say the patient's getting a month of radiation and he has a heart attack, or there's a strike, or there's some catastrophe for whatever reason, the treatment has to stop. This is very bad for the cancer. And the patients get what is called accelerated repopulation, where the cancer gets worse because of the partial treatment. And a concern in this area is that you have the same effect with sublethal energy. So if you have a cancer that's right at the outside of the treatment zone that only gets injured but not destroyed, could the injury response, which involves a lot of what are called cytokines that are stimulatory and growth factors, could that adversely affect the cancer? And that's just something to keep in mind. There is evidence, this is a study of patients having a salvage robotic prostatectomy after focal HIFU, and you can see they had worse erectile function and a worse, this is the likelihood of PSA remaining at 0 was much higher in the patients who'd had salvage therapy. So again, it's a potential downside. I mentioned MRI. MRI also tends to underestimate the tumor volume. This one study showed that the MRI assessment of volume was 1.6 on average, whereas the actual pathologic volume was 2.4, so about a third less. So this is a problem if you're treating in a focal area. I think I'm going to skip that just in the interest of time. So this is a growth area. I may have sounded more skeptical than I intended, because I really believe in this for the right patient. And the right patient is a guy who has a grade group 2 lesion with a solitary lesion seen on the MRI, and the systematic biopsies show no other cancer or only grade group 1. And then there are patients who have more Gleason 4, so they're grade group 3, or they have 2 lesions on one side. They're not ideal, but they're still candidates. And I'm just going to conclude with this technology that I've been involved in the development from the start, called Tulsa, which I think is like the next generation of HIFU. And this is transurethral MRI guided ablation. So this also uses ultrasound energy converted to heat. But the key thing is that the MRI gives you a real-time thermal map of the prostate. So you can see here, the ultrasound energy is being delivered, and you see the tissue heating up on the MRI. It's truly remarkable. And what the system does is it has the temperature that's registered on the MRI drive how much energy is delivered to the prostate. So as soon as the yellow hits the target, the probe starts to rotate, and so it sweeps through the whole prostate, and you can treat an entire prostate with a high degree of precision in about 40 minutes. Here it's actually 25 minutes. You can go back and treat that undertreated area that's in blue, and it also, you know what you've done. You know that treatment has, that prostate has been heated to the point where the tissue is destroyed. And this is some data we presented at the AUA. I did at the AUA just recently, that showed low levels of incontinence and good erectile function preservation, and excellent sort of PSA control and disease control. And this just, again, I just show this again. It's like, it's the most amazing thing. You press the button and all of a sudden, this miraculous energy is delivered that heats just the tissue in the target. It gets out a millimeter or two beyond the target, but this is a very, this is quite a small distance. You know, it's kind of a internally controlled, closed loop is the term, closed loop control system. And then this is at the bottom, you see the effect, this is the MRI immediately after treatment. There's no perfusion or structures or anything, it's just a big black hole. And this, I just show, this is a cystoscopy that I did on a patient who had TULSA and developed urinary retention. He couldn't urinate, and so I scoped him. And so far, it looks pretty normal. Oh, this may not work. But basically, what you see are these two huge cavities. No, it's not. All right. Well, we'll keep going. Anyway, it's quite a dramatic, image. So I think focal therapy has a real future, but we've got a lot of questions to ask. It's going to take the next 10 or 15 years to really address these. Who should get what treatment? Who's a candidate? How widely to treat, and so on. There's a new focal therapy society that's driving this forward, and I really think it's here to stay. And thank you for your attention, and I'd be happy to take some questions and have discussion. And I will try and discontinue my slide sharing if I can figure out how to do it.
Well, Dr. Klotz, thank you for the presentation and for taking the time. I want to introduce Alexa Jett, another moderator who has something to say about another program tomorrow, and then we'll launch into question and answer. So Alexa, go for it.
Thank you, Howard, and thank you, Dr. Klotz, for that informative and fascinating presentation. We all appreciate it here at ANCAN. So everyone, please join us tomorrow. We have a fantastic free webinar. It is Nancy's Top 10, an evening with Nancy Novak, and you are going to hear some great free resources that apply to anyone from active surveillance to high-risk advanced disease. I'm going to be posting the link in the chat, and we hope to see you there.
All right, Alexa, so if you're set, we can start with some questions. Dr. Klotz, you hinted at something I want to ask about, which is the National Comprehensive Cancer Network had recommended active surveillance as the preferred approach for treating low-risk prostate cancer and very low-risk prostate cancer. And on September 10th, they put out new guidelines that reduced the standing of active surveillance from preferred and put it on a par with radical prostatectomy and radiation.
Yeah.
So I'm wondering, what's your take on this?
So, yeah, I've worked with the NCCN in the past, but I have no inside knowledge as to this latest decision, which I think I heard about at the same time as you did from some of my colleagues in the States. But just a couple of comments. Number one, you have to recognize the strengths and limitations of NCCN. NCCN is basically a consensus of expert opinion. So it has people have called it eminence-based opinion, the gray-haired eminences, and so I think it's not the final word on the topic. It may reflect the opinion of some experts who aren't sold on the idea of surveillance, rightly or wrongly. The second thing is, nothing's 100%. So, I'll give you an example. You have most young patients with low-grade prostate cancer have just a few microfoci. But once in a while, you find a patient who is, say, very young and whose prostate is just packed with Gleason 6 prostate cancer. So those are outliers. Those I wouldn't criticize someone who did a radical prostatectomy on that patient, because he really is maybe at risk. So it's not black and white, and therefore I think particularly in high volume Gleason 6, there are still knowledgeable people who think there's a role for surgery or radiation for those patients. Now, I don't agree with that. I do not think, with very rare exceptions, a few percent of cases, more than 95% of patients with grade group 1 cancer should be managed with surveillance, in my opinion, and volume progression should not be a reason to treat. But it's a controversy. And, you know, even in my town, even in Toronto, there are a number of my colleagues who treat patients for volume progression of Gleason 6. And I say to them, look, we know this is a non-metastasizing cancer. This poses zero threat to the patient's life. But they're not sold on it, and that's reflected in the guideline. I think it will have very little impact on practice.
Well, you mentioned doctors in your community. Dr. Finelli from University of Toronto mentions in a study that's coming out in the Journal of Urology in October, you know, he mentions a median time, average time to definitive treatment after initial active surveillance was 16 months. That seems awful short. Is that?
Okay, so part of the problem here is that all of the long-term data comes from patients who were diagnosed before the MRI era. So just to give you a couple of key figures, if you do a systematic 12-core biopsy on a patient, for example, which was the standard between about 1995 and 2012 or so, MRI started to come in around 8 or 9 years ago. You find grade group 1 cancer, 35% of those patients on rebiopsy will be found to have higher grade cancer. And since we do the confirmatory biopsy at around a year, we find upgrading in a very around 25 to 30% at a year, and then the remainder after that. Totally different now. So with MRI and targeted biopsy, that figure's more like 10%. But we haven't been doing it long enough to really see the effect. So I find that data very misleading. A second key point is we know quite a bit about the rate of grade progression. So whereas with systematic biopsy, the misattribution rate is a third, with targeted biopsy, it's 10 to 15%. The rate of grade group 1 cancer actually de-differentiating and becoming something worse. It's been, this has been estimated by 3 groups, and ours is one of them. We all came up with the same number, which is around 1.5% per year grade progression. And it's usually the 3 plus 4, which also may still be an indolent cancer. So it means, you know, at 10 years, you have about 15% of patients who have true grade progression. So what they are observing is simply sampling, better targeting. It's got nothing to do with the likelihood of grade group 1 progressing to higher grade cancer. And you know, so we don't see, we're good friends. He's a close pal of mine, but we don't quite see eye to eye on this topic.
You know, let me ask you something else that is in that report. They found that the dropout rate of active surveillance patients was higher with radiation oncologists versus urologists. Do you see that? Can you explain it?
So I think there's a range of practice. The radiation oncologists I work with are very committed to the surveillance idea, the surveillance approach. But you know, look, I don't know how to put this nicely. The way I see it is that doctors want to make a living, but they want to make a living doing the right thing. There's very few guys who want to make a living doing the wrong thing. Where you have, where financial interests, for example, play a role is where you have a gray zone. And once I kind of conceptualized it this way, I thought my mandate is to shrink the gray zone, to really, it's no longer, and unfortunately, I think this NCCN policy has kind of re-expanded the gray zone. But I think we made a lot of progress towards convincing people that you should not treat the vast majority of grade group 1s, but you have outliers, and you have obviously financial drivers. And you know, that's life, unfortunately. I don't really have an answer for what you're saying. I might say one more thing, which is that me and my colleagues have been passionate advocates for this for a long time. And I also just want to add that the support groups, like early on, I mentioned all the heat that my colleagues and I took early on over this. The support groups were so supportive right from the get-go. And I can remember, you know, coming down from a podium where I'd just been totally pummeled by proponents of aggressive therapy, and some guys from the support group saying, "Dr. Klotz, you are right on. You got to just stick with this." It was very, very gratifying. So, you know, I kind of feel a connection to the support groups.
Well, you can be an honorary member if you wish.
Sounds good. So, but I think maybe the urology community, because the message has been really hammered at them for now well over a decade, maybe they've adopted this more so than the radiation oncologists.
You know, you mentioned the high penetration of active surveillance for low risk or very low risk in Canada. Similarly, in Sweden, but in the US, overall, it's only about 55%, which means the remainder are being treated aggressively. So, you know, what is it going to take to turn that around?
You're not asking me easy questions. You know, I mean, it's a process. We've made a lot of progress. You know, I think you could say the cup is half empty or half full. But look, the American healthcare system has got a lot of problems. So does ours. Ours has many problems too. They're just different ones. But we have less of the American system tends to drive overdiagnosis and overintervention. It's a feature of it, I would say. And I don't know if it's going to take just more education, shrinking the gray zone. I think if there's a shift in reimbursement strategies, you know, who knows what's going to happen going forward. Something's going to change in the American healthcare system at a fundamental level. I think it has to, because it's unsustainable. That's my personal opinion as a non-expert on health economics. But I think it's just become way too expensive. And part of that is the overdiagnosis and overtreatment issue. The incentives need to change. The one thing that's good about our Canadian system, we're not over incentivized. Like, you know, it's not like we have every surgeon is busy. No one is really scrounging for cases. Whether you operate or whether you see patients, you make around the same income. And so I think that's one of the reasons why Canada has been a leader in this whole conservative management approach, not just for prostate cancer, but for a number of other cancers as well, like kidney, testis, breast ductal carcinoma in situ. Many areas, Canada has been a leader in promoting conservative management, because it's not like we need another case to operate on.
Let me, you know, you're kind of I'll ask one more question. I'll give Alexa a chance. But you're hinting at economic and cultural differences between our countries. But one difference, I think, and maybe you can address this, is what about genetic and genomic testing for active surveillance? Is there a difference between the US and Canada?
First of all, thank you for getting away from the economic story, because I'm really, this is not my expertise, although I have opinions. But yeah, so this is a phenomenally rapidly moving area. So the key point, I didn't go into it in detail when I was talking about the BRCA, but these assays for genetic characterization that used to cost $50,000 now literally cost a couple of $100s. So that, for example, the color test, which anyone can access, costs $249 US, and it is quality science, and it gives you pay, you get the kit, you send back some saliva, and you get a report of whether you have cancer predisposition genes, including the whole range of DNA repair defect genes like BRCA. And so, that's for what it is, it's very inexpensive. And anyone who's got the slightest hint in my practice, meaning family history of breast or prostate cancer, or someone in their family, particularly if they died of advanced prostate cancer, any patient who has advanced prostate cancer like metastatic disease, and increasingly the surveillance patients, I encourage them to do it. Now, the problem is if it comes back positive, we have a problem, because it takes about a year or more to get into a genetic counseling clinic. And that is not my expertise at all. What are the implications for the other family members, et cetera? But about 4% of patients on surveillance will have one of these defects. And when you find it, it obviously makes a huge difference, not only to the patient, but to their family. So I think we're reaching the point where I think everyone's going to get this done. But I do it on most surveillance patients now.
Okay, Alexa, you want to pick it up?
Yeah, Dr. Klotz, I think I have a few easier questions for you to give you a little bit of a break. Yeah. So we have a question. What tests should be considered conducted before considering active surveillance? MRI, PET scan, potentially others?
Yeah. So, okay, so that's a nice basic question, and thank you. It's really good one. So we're in the MRI era. So Canada, for example, has just changed its recommendation for diagnosis that patients who have an elevated PSA should have an MRI before biopsy. So increasingly, and we are actually in the process of struggling to adjust to that, because some patients really can't access MRIs at all. I think the micro ultrasound has a role there. I view it as imaging before biopsy, whatever it is, whether it's MRI or micro ultrasound. So increasingly, the patients have already had the MRI, and they've already had a targeted biopsy. But if they haven't, they should have one within the first year. You have to wait 3 months after the biopsy because it introduces some artifact into the MRI. And then we follow patients with MRI and or ultrasound roughly every 2 to 3 years. And we repeat the biopsy if everything is stable about every 5 years. And that's, roughly the intensity of follow-up for the average patient. Some people, at Hopkins, they did annual biopsies every year. They really only did that for science. They did not do that because they thought it was necessary, and it is clearly not necessary. Where you have a rate of disease progression of 1.5% per year, you don't need to be too intensive with the repeat biopsies. Once you're satisfied the patient doesn't have anything else.
Yes, absolutely.
Yeah. Okay.
I actually have a follow-up question that someone else asked that it kind of goes into that vein. We're sort of talking about the past, present, and future of active surveillance. So this person wants to know, what will active surveillance look like perhaps in 5 to 10 years from where we're sitting now? Will MRI ultimately replace PSA? What role will micro ultrasound play?
Okay, so that's like 3 or 4 different questions. But so first of all, what the biomarkers, I believe, I think the way the whole diagnostic algorithm works is going to be different. It'll start with PSA, because if the PSA is low, there's very good data, for example, that a PSA of 1.0 or less at age 60 means the patient has almost no chance of dying of prostate cancer ever, even for the next 20 or 25 years, in the range of 2 per 1,000. So that is incredibly valuable, even though the PSA has a lot of other limitations, but that it's called the negative predictive value. The value of a low PSA is just massive. My father died of prostate cancer, and when I turned 60, I had a PSA of 0.9. That was very reassuring that, you know, this was not going to be my issue. At least I hope not. So then, instead of imaging, it's going to be a biomarker, and whether it'll be the select, the sentinel assay or one of these other ones, the select assay also looks promising. And then the patients who have an abnormal value on the biomarker, and the biomarkers are getting so accurate, so you're going to be able to identify the patient. You basically will know with almost complete certainty this guy has the real deal. Then you do the imaging, then you see the lesion. By the time you get to the biopsy, you're not doing it to find out if he's got cancer. You're doing it basically to assess his Gleason grade. And it you know, maybe we won't even need the biopsy eventually. We're so reliant on the biopsy now. I think that's pushing the envelope, but you never know as these biomarkers get better and better. There's this concept of liquid biopsy, meaning you actually see the genetic manifestation of the cancer in the fluid. And then, you know, it's telling you something very real. So that's what I foresee. The MRI is not competing with the PSA. The MRI is not going to replace it. And the MRI is going to remain a key part of this. PET scanning, that was your previous question, really has very little role so far but although it does, the PSMA scan is more likely to be positive with higher grade cancer. But the data I've seen so far shows it's not a whole lot better than MRI. It gives much less detail. So I don't see it having a role just yet in that area. And what else did you ask me about?
Micro ultrasound.
Oh, so, well, I'm very partial to micro ultrasound. It's complementary to MRI. It's not going to replace it. They each have their strengths and weaknesses. The data we have is that in a population of men suspected to have prostate cancer, they both show the lesion in about 3/4 of cases. And in about 15%, only the ultrasound is positive. And in about 10%, only the MRI is positive. And so you know, the ultrasound is cheaper. It's also, it's done by the urologist rather than the radiologist. So urologists like it a lot. And, you know, as I mentioned, in places where there's lack of access to MRI, I think it's got huge potential. The value of the MRI is, the MRI lends itself to very close analysis after the fact. The images are collected. The radiologist can spend 15 or 20 minutes looking at all the images. You can use artificial intelligence increasingly to interpret the images, whereas ultrasound is real time. You put the ultrasound in, the guy who's doing it is looking at the images. So these both have their strengths, but they're complementary.
Alexa, let me step in now and take note that the meeting was called to end around now, but Dr. Klotz has agreed to stick around for another 15 minutes. He
Yeah.
started the day with a meeting in Manila, and I know we're wearing him down.
It's all right.
Let me,
All good.
okay, let me ask you a couple of questions that come in today, just so that the audience knows. We get the questions submitted by email in advance. We got a lot of those this time, and we also got questions submitted today. So let me ask you something that was submitted today, but also previously. They want to know about the role of medications like, let's see, Avodart, which is used for BPH. What is the role of that in active surveillance, and what are the concerns about long-term use, if any?
So it can be used in men on active surveillance if they have large obstructive prostates that's interfering with their urinating, but it's got nothing to do with the prostate cancer. So in my opinion, it has basically no role for the management of men on active surveillance for their cancer. And there's several reasons for that. One is these two drugs, dutasteride and finasteride, or Avodart and Proscar, they have side effects. They reduce libido. And a drug that's being used for prevention that has side effects is not a good drug. By definition, a drug for prevention has to be very, very free of side effects, or it's not worth it. So number one, it's got side effects. As you may be aware, there's class action lawsuits by men who have been on Avodart for a while and claim their erectile function libido never recovered. So I don't think that's trivial at all. Second, low-grade prostate cancer, we don't treat it because it doesn't pose a threat to the patient. You're treating a kind of a pseudo disease that you don't need to treat. The third thing is that if Avodart does have enough benefit, it's on the low-grade prostate cancer. It shrinks the cancer cells and the normal cells, but it has little or no effect on the higher grade cancer cells. So it actually, it's not treating the cancer that you want to treat. It's treating the one you don't need to treat. So I use it in these men if they have an indication for the drug because of their very large prostates, but not for cancer.
Okay, I have a couple of liquid biopsy questions. One of them is the sentinel test. Can it distinguish between Gleason levels, or to say it another way, low grade versus high grade PCA, prostate cancer?
So
and also, there was a much touted liquid biopsy. And just so people know, in these cases, these are, I think, in Dr. Klotz's research, it's a urine test. Somebody asked about that. But there was the GRAIL test, which found all kinds of cancers through liquid biopsy, but it didn't find prostate cancer. So, how good is the sentinel test, and why can it find cancer when the GRAIL test doesn't?
Okay, so the Sentinel platform is very specific for these microRNA sequences that are shed by prostate cancer cells into the urine. The GRAIL test, if I'm thinking of the right test, is a test for circulating free DNA. Mm-hmm. So cancer cells, particularly when they die, their DNA is released into the blood. And that is the basis for that. So it's an extraordinary concept of a blood test that can detect kind of any cancer that's present in the body. The problem is it mostly detects more advanced cancer. So for example, localized prostate cancer, it's a fairly slow growing cancer. Therefore, the more rapidly growing the cancer, somewhat paradoxically, the more cancer cells are dying because they're turning over very rapidly. So with more advanced cancer, you get this free DNA, but with localized prostate cancer, most of the time you can't detect any, even though the assay for this is unbelievably sensitive. Like, and it can detect, you know, just a few molecules of this free DNA, and then you characterize it for the mutations that are specific for different cancers. So, you know, why one cancer shows up at an early stage and another doesn't, that's just kind of a characteristic of the cancers and their growth rate. So there's no inconsistency there. Looking for free DNA in blood is a totally different type of approach than looking for microRNA shed in exosomes into the urine by prostate cells. The same approach, by the way, can be used for bladder cancer and probably for kidney cancer. That's a whole other story. It certainly works for prostate cancer.
You know, I talked to you earlier this year, and you said you were kind of on the fence between transrectal versus transperineal biopsies.
Not anymore.
And what part of the fence did you land on, and why did you change your mind?
I switched about a year ago. So you know, there's pros and cons. The transperineal approach, I assume your audience knows what that refers to. That it doesn't, there's an ultrasound probe that goes up the rectum, but the needle goes through an anatomic area called the perineum, which is the area, fairly small area between the base of the scrotum and the anus. Is called the perineum, and the needle goes in there and it goes into the prostate. The downside is the needle's got to go a lot further to reach the prostate. So it's a little more, it requires more skill to do it well. But once you have learned how to do it, it's pretty straightforward, and it's clearly safer. And you know what influenced me? I was kind of trying to decide whether to switch, because I'd been doing transrectal biopsies for 20 or more years. I was totally comfortable with it, but we had this persistent problem of patients who got infections afterwards. About 1 to 2% of patients, even though we increased the level of the antibiotics we were using. We gave patients an intramuscular shot of a very strong antibiotic. That dropped it from 4% to about 1%. But still, you know, doing like 5 of these a week, 1 in 100 means every few months I get a really sick patient from my intervention. No deaths personally, but then I heard about, I know you know this story, that I heard about this Norwegian story where this 65-year-old Norwegian guy had a transrectal biopsy and got infected and died. And he had a kind of prototypically Norwegian-looking wife and daughter who made a public relations campaign over this, and he essentially forced the urology community to switch. And basically the insurers in Norway said, we're not going to insure you for doing transrectal biopsies anymore. And they switched. And I thought, you know, there's a message there. There's a better way to do it. And even though it's a little more time consuming, it's safer. And I've switched over. It took me a few months to kind of get the hang of it, but now there's no going back. I think it's a much better technique. And when I talk to patients about having a repeat biopsy, when I was doing it transrectally, and I'm sure your audience can relate to this, you know, I'd say, you need another biopsy. They go, oh God, no, you know, I forget it. And now I say, you know, we've changed the technique. We're doing it transperineally. There's no issue with infection or bleeding, and they are reconciled to that. So I think it's a better way to do it, period. And gradually, I think practice is changing.
Well, you know, you mentioned the Norwegian story. What is the message about patient power from that? What role can we as patients play?
Well, Yeah, I mean, that was really a great example of patient power. It didn't hurt that they were very sort of appealing looking women who, you know, they could go on the front page of the newspaper as having this campaign to change practice. It was a great story. I'm not sure everyone can pull that off, but I think you know, public pressure is very powerful. And so I think the support groups can really play a role in this. But you know, it's not easy to change practice. You gotta push.
Gotcha.
I just want to say real quickly, I'm so glad that all of, and I say that's at the Active Surveillance Support Group, all of the people who attend all of our prostate cancer groups are very handsome and attractive, and Can just knows how to get them. So
Absolutely.
I'm sure they're great advocates in every way that they can be, and we all love them.
Yeah.
I'll tell you, we have about 2 minutes left. And we probably have only gone halfway through all the questions.
I was too long-winded, Howard.
No, we just have short attention spans, I guess. Oh, well, here's one I wonder about too. So he's talking, we'll make this the last one, I think. He's asking, is there a parallel in high resolution micro ultrasound to color Doppler? And, you know, a lot of us have never had color Doppler. You know, what is color Doppler as far as prostate cancer? And is it widely used, or is this sort of like a voodoo thing?
I think it's a bit of a niche done by some ultrasonographers who are very immersed in that area. So obviously Doppler detects motion, and it's a way of essentially identifying blood flow and abnormalities in blood flows. And one of the characteristics of cancer is a change in the vasculature, or the blood vessels that feed the cancers. Cancers, as they grow, need to generate their new blood vessels, or they won't be able to grow. And you can detect those abnormalities with this color Doppler technique. It's not. I don't think it is as good as the micro ultrasound. It's harder to use. You have much more kind of non-specific findings. It's not that easy to differentiate a normal from an abnormal clump of blood vessels, and it's not as specific. So I think it's kind of it was a way to improve the performance of conventional ultrasound, but I think that the micro ultrasound is going to prove to be a superior technique. That is a personal opinion. There are ultrasonographers who don't agree with that, who think the color Doppler is, you know, has got a future, but I don't see it.
Well, listen, you did a great job, and I don't think we just have one more thing to do. And the chairman of the board, our own Frank Sinatra, Herb Geller, will have some closing comments.
Thank you, Dr. Klotz.
Pleasure.
I'm really pleased the way we learned a lot from Dr. Klotz tonight. I mean, I myself am a more advanced cancer patient in the prostate area, and certainly learned stuff that is going to be useful to me in my journey. And so I really, you know, everything you said for active surveillance, I think has little tidbits that we can apply in the field of prostate cancer treatment, surveillance, and for the patient information. So really, from all of us at ANCAN, I want to really thank you very much for everything. I also want to remind the audience that ANCAN does have active meetings for support groups in the areas of active surveillance, young cancer patients under 60, and more advanced cancer patients, and they can be located on the ANCAN website at ancan.org. And so if you've enjoyed this evening's presentation and want to learn more about how ANCAN can make your life more tolerable and learn more about your conditions, please consider joining one of our groups. And thank you very much, Dr. Klotz. I really appreciated this presentation.
Thank you, and I really enjoyed it. Good night, everybody.
Good night.